You guys know how to do this, right? How do you diagnose pregnancy? Well, I've already given you the clinical signs and symptoms. Beta HCG. So, two types of beta HCGs. Qualitative, quantitative. Qualitative is the urine. Quantitative is serum. Okay? That's probably going to be a test question. Just saying. You need to know that when you're checking your urine, you're checking for qualitative, just positive, negative. When you check in the blood, you're checking for actual levels, you're quantifying it, okay? As I said before, home tests are not as accurate. Always confirm it, always repeat it. But false positives are extremely rare, okay? Like that's just almost unheard of, a false positive. So if they've had a home pregnancy positive test, it's probably positive, but confirm it, okay? So by the time they miss their first period, that's when you're going to be able to see it on a urine, okay? You're not going to see it as quickly with urine as you will with a quantitative. Quantitatives can check it as low as 1 milliliter. So, I mean, they can check minuscule amounts of beta HCG. If you need to know, like within a week of conception, you do want to do a blood quantitative HCG. A urine will not pick it up that quickly. It's not sensitive enough. And about 44% of the ones you buy off the shelf at Walgreens or Walmart are not going to detect it. Okay? So it's going to be a false negative. So when patient, now I know this seems probably just very basic to you guys, but patients need to know, and I think somebody talked about this, maybe in the infertility lecture. I can't remember, but you have to have a positive control for it to truly be positive, okay? If you have a positive here, but your control doesn't pop, that's invalid, okay? So for it to truly be positive, the control and the test have to be positive, okay? If you have a urine beta HCG that comes back like this, probably user error. I mean, they may not have peed on the strip or something, so do it again. But don't call this one positive, because something's wrong with the testing material because the control didn't work, okay? Seems pretty basic, but sometimes you have to think it through, make sure you're thinking about it right. Okay. The old test books, the old test questions will tell you that the quantitative beta HCG doubles every 48 hours. And I don't know why that was ever a thing. Because if you are actually watching a beta HCG, to consider it rising normally, it should rise by about 50% in 48 hours, okay? So be conservative with your rising HCG. What did Dr. Gibson talk about that has astronomically high levels of beta HCG? Molar. Yeah, and I said this to somebody the other day, it might have been Ryan, talking about ectopics. Ectopics can actually rise normally at first, and then they'll drop off. But a molar pregnancy will have like astronomically high beta HCGs, okay? So, where you're going to, go ahead.
What's a molar pregnancy?
So, gestational trophoblastic disease. It's in Dr. Gibson's lecture. Okay? It's basically like cancer growing instead of a fetus. Not always malignant, but it grows way out of proportion than what you would expect a normal pregnancy to grow. Okay, so where your quantitative beta HCGs get kind of tricky is where when you're trying to rule in or rule out an ectopic. Okay? So let's say you have a pregnant lady. She's having some weird pelvic pain. You're worried about an ectopic. Let's say it's a 25-year-old girl. You check a urine pregnancy, she's positive. What do you want to do next? You don't necessarily want to do a quantitative yet. You might just do an ultrasound, right? See where it is, okay? Let's say you can't see it. You don't see it in the uterus, but you don't know how long she's been pregnant. So now you get a quantitative, now you get a serum. Okay, this is where where you need to remember this level here, okay? So if you check her beta-HCG in her blood, and it's between 1,000 to 2,000, to be conservative, let's say 1,500 or above, you should be able to see an intrauterine pregnancy. I mean, you should be able to see a gestational sac, okay? So you're now really thinking, okay, well, her beta-HCG on her quantitative beta-HCG is, let's say, 2,500. I should see a gestational sac. So that, you need to know that range, okay? You need to know when you should be able to see a gestational sac on a transvaginal ultrasound. So if her quantitative beta-HCG is 2,500, you do a transvaginal sonogram, you don't see a gestational sac, but you don't see it on the tubes or the ovaries or anywhere else. It's still an ectopic pregnancy until proven otherwise, right? Okay. So at that point, that's when you'll do serial beta-HCG. You'll check it again in a couple days and see what it does. Okay. And Dr. Gibson talked about that. You might listen back when you look at that lecture again. There's more information on that in her lecture. So, broadly, beta-HCG that's too high, molar pregnancy, it can be multiple gestations, it could be twins. But the most common reason is that they just don't have the dates right. Okay? So if they're not having bleeding, not having pain, there's no reason to get too concerned yet. Okay? It can be too high in Down syndrome. The opposite is true for trisomy 18 if it's too low. Beta-HCG being low is indicative of trisomy 18. We'll see that here in a minute. And then too low again. Only half of ectopic pregnancies is the beta-HCG going to be too low. Actually, it will start to rise normally. Okay? So you have to rely on your ultrasound and are you above the threshold where you should see the gestational sac? Okay. We call that zone the discriminatory zone. To be more conservative, it's usually we call that zone 1,500 to 2,000. If we're in that range with a quantitative beta-HCG, again, we should see evidence of a gestation. So if you're above the zone, that you cannot see in IUP is intrauterine pregnancy on transvaginal sonogram, it's either a non-living, meaning an empty sac or just tissue that's not going to be viable, or it's ectopic and it's growing somewhere else. So at this point, you've got to do serial beta-HCG to see if it goes up or down. It may just fizz out and go down and she has a SA, okay? But if it keeps rising, then you're worried about this pregnancy growing somewhere where it shouldn't be. And then this is a good thing to remember too. I mean, if you check that level and it's above 3,500, by that time, 99% of the time you're going to see, if it's in the uterus, you'll see it. So, but your discriminatory zone is 1,500 to 2,000. Anybody have questions on that? 'Cause it's very confusing when you're just learning it. Okay. All right. So. Again, this is just a tiny little sac you're trying to find. Okay, you're just looking for that little anechoic, so non-echoic area within the uterus. You don't need to memorize. I'm not going to test you on those layers. You just, I mean, it's good to know that there's 2 layers you can see on there, but don't memorize the names. This is another good picture of it. There's a little yolk sac, but you can't really see a fetus yet. So the fetus is just kind of this tissue in there somewhere. That's what it should look like. So you'll see that at gestational age of 5.5 weeks. So it's been 5 weeks since her last menstrual period. So that's like 3 weeks after implantation. About, again, you don't really know exactly. It's early on, you can see that. And then remember, you see that little heartbeat in the. You start seeing the little embryo at 6 weeks, and start seeing the heartbeat at 6.5. Okay, so again, more about serial. Serial beta HCG. They are usually repeated. They don't repeat them in 24 hours. They repeat them in 48 hours to give it time to do something. If you cannot find the little sac on ultrasound, you call it a pregnancy of undetermined location. So it's basically it's an ectopic until you can find where it is. Then what you're looking for when you repeat the beta HCG is you're just looking for if it's going to rise or drop. Okay, so basically if it fails to rise, so if it just kind of hovers and stays the same, or if it doesn't rise or even drops, then it's probably failing. But some ectopics will keep rising, so you have to watch that. I put that little bit of information in there for you too. After a spontaneous abortion, so their level, let's say that you recheck it in 48 hours and now it's dropped by 50%. So you can be pretty certain it's a failed pregnancy. It's a spontaneous abortion. So then you need to know that within a week, it's going to be nearly back down to normal. But you got to follow those until they go all the way back to less than 5. Now, you've rechecked it in 48 hours and it has continued to rise, so you recheck the transvaginal ultrasound and you still don't see the little sac in there, then you pretty much know it's an ectopic at that point. Okay? So it's a viable pregnancy. I wouldn't really call it that, but it's trying to do what it's supposed to do, but it's not in the right place, so it's doomed. But if it starts rising, and you always get the ultrasound again, see if you can see it. At that point, you may be able to see it on the tube or outside the uterus or some other place. And then if it rises and then you're like, see the sac in the uterus, you're like, whew. I'm sure you're pregnant. Okay. So you kind of have to know what's expected to know if it's abnormal, right? So what you expect, again, is at least about a 50% increase in 48 hours, okay? That's going to be your ballpark. If it doubles, great. And you know it's really doing what it's supposed to do, okay? But even a 50% rise at 48 hours is good. Okay, that's at the bottom of the threshold. It might double, and that's okay. That's not abnormal. You're kind of watching for the bottom of the threshold, which is, if it at least increases by 50%, you're all right. But like I say, be conservative. Some normal intrauterine pregnancies only rise by about 35% at 48 hours, and they end up being, there's nothing wrong with it, it's just fine. So what I would avoid doing is saying, well, your beta HCG only rose by 43.7%, so I'm going to give you some methotrexate to go ahead and finish off this spontaneous abortion. You know, I wouldn't do that. I would keep watching it. Just like I say, be conservative. Give it some time to increase. Now, what you need to know with multiples is that it doesn't rise any faster in multiples. The rate of rise should be the same. So no matter what it was when you checked it the first time, it should increase by at least 50%. It won't double faster if it's twins. Does that make sense? The other thing to remember on following serial HCGs is that 30% of ectopics will have a normal rise at 48 hours. Okay, we talked about that before, I've said it twice now. But an HCG that's falling down with an ectopic does not mean it won't rupture. It might still rupture. So, again, refer that patient on, get them to a specialist, they're going to need a DNC. So, take-homes on HCGs are at least a 50% increase at 48 hours. You check them every 48 hours. If it's above the threshold minimum and you don't see it in the uterus, it's an ectopic until proven otherwise, especially if they're having pelvic pain or vaginal bleeding, okay? This is one of those think it through charts that kind of talks about you're in positive pregnancy with pain or bleeding. You guys have to just look at that when you have a minute, when you have time, when you review this. Progesterone can also be used to determine if the pregnancy is viable or not. It doesn't necessarily rule it in, but if the progesterone, or it doesn't necessarily say the pregnancy is perfect and going as expected, but if it's less than 5, you can pretty much bank on it being something wrong, okay? Levels at -5 are found in only 0.3% of normal pregnancies. So if you've got a level under 5, you know, something is impending. It's pretty limited. There's a lot of people that don't use this. They might use them if it's an older woman that's pregnant. So on your first prenatal visit, these are all labs you're going to get. This is straight from the ACOG website on from the antepartum record. You're going to check blood type. You're going to check for whether they're Rh negative or not. The Rh blood type is also called D. Does everybody understand that it's A, B, C, D, and we only worry about D. D is Rh, okay? Antibody screen, which again, that's for the Rh. CBC, you do a pap smear at the first visit. That also can get your GC and chlamydia. They are recommending that everyone be checked for chlamydia, okay? Just because you're going to have to swab in there anyways to do the pap. So check for chlamydia because 10% of people have it, don't even know it, at least 10%. You do need to, in all your females, check a VDRL for syphilis. In all your females, confirm that they have no HIV antibodies. An initial urine, make sure you're not spilling glucose. Those are that's the bare minimum of what you need to do on everyone, okay? If they have a history of gestational diabetes with a prior pregnancy, you might go ahead and do a glucose tolerance test or order a glucose tolerance test early, but you don't have to. And then your electrophoresis, your PPD, all those things are, you know, if they have risk factors. But again, I would check chlamydia on everybody. Who has learned about Rh stuff in the past? So some of you guys have had some of that? Okay, good. So the mom is negative. The dad has to be positive so that the kid is positive. But it can be homozygous or heterozygous. So if they have a positive dad, it doesn't mean they're necessarily 100% going to be positive, okay? It's basically exposure to the antigen, the Rh antigen on the baby's blood that causes the mom to make autoantibodies. First pregnancy is not an issue because she's not autoimmunized yet. But there is some very slight risk that a woman had a spontaneous abortion, you know, 3 years ago, and that baby was Rh positive, and they had no idea that she had no idea if she exchanged blood with it, and she might be already immunized. You just don't know. So you err on the side of giving everybody RhoGAM who's Rh negative. You just don't even worry about testing it. It's safe. So every Rh negative mother will get RhoGAM, okay, to prevent hemolytic anemia in the newborn. They don't get it until later. We'll talk about it in a minute. Torch panel, checking for infectious things, toxoplasmosis. That's the one that's in the cat poop. Tell your pregnant ladies, don't change the kitty litter, right? Who has taken care of pregnant ladies before in a clinic of some kind? Anyone? You did some peds? Nobody? Okay. Don't change the cat litter. Don't eat the canned tuna, too much canned tuna. All these weird things they can't do. Have they had rubella is very important. Because not the rubella vaccine, have they either been exposed to rubella and have immunity to it, or did they have the vaccine and have immunity to it? But just because you have the vaccine doesn't mean you necessarily created the antibodies and are immune to it. So you have to screen everybody for rubella immunity. The cytomegalovirus is the other one that can cause problems in pregnancy. Most people by the age of 40 have had CMV. There's just like a viral illness, a mild viral illness that they didn't even know they had. But you do need to confirm that all your pregnant women have had it. If they haven't, they need to be extra careful about being around sick people. Don't get CMV while you're pregnant, okay? It just gives them the opportunity to control their surroundings a bit and keep their baby safe. And then, of course, herpes. You need to know if they have herpes simplex, because that can complicate delivery. You've heard about chlamydia before. What you need to know about chlamydia for pregnant women is if they are positive, you need to treat it. You can give them the gram of azithromycin, and you need to treat their partner. In the state of Oklahoma, it's potentially allowable that you can treat the partner without, just send home the prescription and give it to the partner as well, so that they don't reinfect the pregnant lady. But why would you prohibit this? I do not know. Why does Oklahoma not have a law that says it's okay? I don't know. Don't get me started. So on subsequent visits, now you're going to get into these more special tests like the maternal alpha-fetoprotein. So if you want to start screening for congenital abnormalities, chromosomal abnormalities, you're going to offer this to the lady at a later date, somewhere around 15 to 18 weeks probably. We'll talk about that here in a minute. Everybody gets a glucose tolerance test in that window, 50 grams of oral glucose, and then check the blood sugar an hour later. Should be less than 140. If they fail their screen, they get a 3-hour glucose tolerance test. So the screen, we'll talk about it more in a minute. The screen you just do in the clinic. It doesn't require fasting or any special instructions of any kind. You just do it while you're there. Everybody gets RhoGAM if they're Rh negative at 28 weeks or thereabouts. Okay? If they have a spontaneous abortion, they get RhoGAM if they're Rh negative. If they had no prenatal care and you don't see them until they're 37 weeks and they're Rh negative, you go on RhoGAM. Why do you give them RhoGAM in the first pregnancy? If it's not till the second pregnancy that there's a problem. Right. You're basically, you're blinding the mother's immune system so she cannot respond to the Rh antibodies. So you have to give it with the first pregnancy to prevent it from happening later. And then the group B strep we'll talk about in a minute. So this is your lovely orange drink. Ugh. You guys need to remember, I will give you a test question of what is a normal glucose tolerance result. I told you right now, everybody should get that lab medicine question right. Less than 140 at 1 hour. If you fail it, you get a 3-hour. 3-hour, you have to fast, and you have to get stuck 3 times. Well, you have to stuck 4 times, because you got your baseline, 1 hour, 2 hour, and 3. And I don't know why it says, 1, 2, 3 hours thereafter. Meaning, you don't keep checking it, it's just 1, 2, and 3. Okay. Who gets offered the maternal serum alpha-fetoprotein in between 14 and 22 weeks? You can offer it to everyone. How many pregnant ladies in here were offered blood testing for chromosomal abnormalities? And you had the choice of whether you wanted to do it or not. I didn't do it, just because I wasn't going to change anything I did. But you can offer this to them as early as 14 to 22. Some people want to know if something's going to be wrong. Some people don't want to know, just deal with it if it happens. So it's just some ladies may not want to check, some may want all the information. I'm sure Professor Brooks would have wanted to check once a month. I'm just like, well, we'll deal with it if it happens. But it's most accurate between 16 and 18. It's screening test, because if it comes back positive, it's not mean they have going to have a birth defect. You definitely want to get it if they have a personal history of birth defects, family history of birth defects, family history of Down syndrome, things like that. Oh, and advanced maternal age. Remember, you're elderly, you're over 35, and you're pregnant. So, advanced maternal age, over 35. But all women, regardless of age or anything, have a risk of birth defect up to 5%. So, that's where you can offer it to everybody. It's not specific, because if it comes up positive, only 2 out of 3 in 100 will have a birth defect. So it just tells you to go looking. Okay. So it's a screening test. It's not meant to diagnose. It's meant to screen a population of people who are potentially at risk. The other thing that alpha-fetoprotein is elevated in is liver disease, liver cancer for sure. So remember that. The mother has hepatocellular carcinoma, hepatitis B for 30 years, and has hepatitis B. Their alpha-fetoprotein will be high as well. So if it comes back abnormal, definitely an indication for an ultrasound. Okay, possibly plus or minus an amniocentesis as well, but at a minimum, they're getting another ultrasound. So what things are abnormal? So maternal serum alpha-fetoproteins can be checked just themselves, but they're most often checked as a part of a triple screen. Has everybody heard the word triple screen or quad screen? So triple screen, they check 3 different levels. We'll talk about them in a minute. Quad, they add an additional 4th thing that becomes more specific to different diseases. So if you're just checking the alpha-fetoprotein, it's most commonly high in neural tube defects, gastroschisis, that's an omphalocele, basically where the guts form outside the body. Multiples, again, liver disease in the mom, but by far the most common cause of it being high is that we don't know the actual gestational date. So again, don't freak, it's one of these things like don't freak out if it's high, we'll get some more testing and see. Okay. Things that it is low in, the big one's going to be Down syndrome. It can also be low in trisomy 18 as well. It is good to know that insulin-dependent diabetics make less of this, but they factor that in when they figure out the level on the lab. So it's more diagnostic if you add it to a triple screen. So you're checking estrogen levels, alpha-fetoprotein levels, beta-HCG levels, and then you're using the 3 in combination to make a prediction. Okay. The triple screen, again, these tests are best between weeks 16 to 18. And this becomes a bit more predictive if you look at these 3 in conjunction. Again, the one you're going to look at, if that alpha-fetoprotein is low and the beta-HCG is high, you're worried about Down syndrome. Okay. If they're all low, it's more predictive of trisomy 18. If the other 2 are totally normal, but it's still just the alpha-fetoprotein that's high, then you're looking at the omphalocele and the neural tube defects. Now if you add the next If you add the inhibin on there, then it becomes even more sensitive and specific to these different diseases. Okay, now you can screen for Turner syndrome. But again, those neural tube defects, it's the same. There's still the others aren't responding. It's just the alpha-fetoprotein. So you guys can look at this later. I will tell you that the ones that I'm most likely to test on are going to come from this chart and this chart. So I would study those two. And I definitely know which things you're checking for on the triple screen and which things you're checking for on a blood screen. And what weeks they're helpful, because they're most predictive in 16 and 18 weeks. Good test questions. This just shows as you add the next test how much more predictive they become. Okay. So your special test in pregnancy. Now, if you have a patient who is either extremely worried about chromosomal problems or has a family history of chromosomal problems and does not want to wait until that 16 to 18 week time period and wants something done earlier, this is a good option for them. I cannot comment on insurance covering this. I don't think it does. If anybody else has experience with it and can comment, let me know, but I would assume you'd have to pay.
I have some friends who have done, I don't know if it's this test, but it's the really comprehensive one, and TRICARE does cover it.
Okay, so there may be, that'd be something you would look into. If you have a patient that, again, is either has family history, personal history, or is just wanting everything checked, okay? So the basic one just started years ago as the Maternity T21. It was just to look for Down syndrome as early as 9 weeks, 9 to 10 weeks. Again, not diagnostic, you still have to do a follow-up test to diagnose it, but it can be done so much earlier. So from this test, they've built up to this Maternity T21 Plus. You can check for 21, 18, 13, all of these common, and I didn't even list them all out. I mean, it's just Angelman, you check for that, and check for the Crudicot or whatever that Professor Paulk's brother has, Turner syndrome, Klinefelter. So you can know these things as early as like the 2nd month, 3rd month. So this is well before you're going to be seeing grossly abnormal things on ultrasound, right? Some indications to encourage your patient to do it is the advanced maternal age, again, personal or family history. If they've had an ultrasound where they can already see something, you'd want to screen them for all these things. And then they've already had a positive screening test. So let's say they had the alpha-fetoprotein came back really high. You could offer them something like this to get a bit more specific. So if these genetic screening tests come back positive, what do you do then? You do an ultrasound, you don't really see any fetal anatomical abnormalities. What do you do? Well, as early as 10 weeks, you can get CVS, okay? So this can be done through the top of the abdomen, or it can be done transcervical. They basically just aspirate with a needle. And I don't know the technical way, but they go in and they get tissue. It's actually from the placenta, because that will match the fetus. And they can actually do a karyotype from those fetal cells. This is the only way to do a paternity test prior to delivery. I found that interesting. So there may be court-ordered stuff. You have to do CVS. But this one can be done this can be done the earliest. If you're going to go sampling some tissue, this is what you would do. It can be done as early as when the fetus looks like that. It is a little bit higher risk. The miscarriage risk is up to 5%. Anytime you go sticking needles places they don't belong, you're at risk for infection. I would assume the distal limb defects would be from like stabbing the little fetus with the needle.
ABS.
Say again?
ABS.
And then premature rupture of the membranes. I mean, if you were to poke a hole in there and going transcervical, poking a tiny hole in the amniotic sac. And so there are some risks. But you can do it a lot earlier, you can get your results really fast. So it's something, these are high risk OBs are going to be doing these things. Since we're running late, I had a video, y'all can watch this later. It's nothing that important. Now we get to the bigger one is the amniocentesis, and look at that needle. So for this one, this is when you have to do it later, after 15 weeks. You can do this all the way up through the 3rd trimester. My mom had this done when she was pregnant with me late in the 3rd trimester. But she would talk about how long that needle was. It was like this long, going in her belly to get to aspirate fluid. But this is used, for me, was used to assess fetal lung maturity because I was premature. But if you need chromosomal testing, gender testing, why you would need to do that, I do not know. But you can actually go out and aspirate some amniotic fluid that's going to have fetal skin cells or just kind of washing around in it. So they're basically in a bath for 9 months. So there's going to be some sloughed off fetal cells. Your indications for amnio are going to be advanced elderly mothers, right? If you've had prior pregnancies with issues, again, you're detecting these things later. The risks for amnio are much less than with CVS. Okay, it's a less risky procedure. You are at risk for infection again and preterm labor. Choriocentesis, you're actually aspirating blood out of the umbilical cord itself. Okay. This is going to be more to look, you can do chromosomal stuff through this if you actually need blood, but to look for infections or to look for the hemolytic type stuff, you can aspirate the blood out. I mean, this would be a very specialized situation. I basically just want you guys to know that this is a thing and you can do it. Okay. And it's the last resort. Ready for game? 3rd trimester, really, all you need to remember is repeat your CBC. If they have, let's just say she's turning tricks, you never know. Check for STDs again, okay? Check gonorrhea, chlamydia, syphilis if she's been exposed, if she's changed sexual partners, if she's a sex worker, things like that. You want to check STDs again, not in everyone, okay? And everyone gets a CBC, maybe an ultrasound if you need to assess fluid or something like that. And then everyone gets the group B strep, okay? Dr. Gibson talked about how this has dramatically lowered neonatal mortality and morbidity. About 1 in 4 women are colonized. It's just a normal occurring bacteria in the perineum and vagina. By swabbing and checking for this and then giving IV antibiotics at the time of delivery, the infant mortality rate has dropped and morbidity has improved as well. It prevents not only for infection that they get right at the time of delivery, it prevents them from getting group B strep sepsis, week to later. What we're worried about here is sepsis in the newborn, amniotic fluid getting infected, and of course miscarrying or causing stillbirth. And that's just showing how much we've improved things since we've implemented the screening procedure. So everybody gets that. You don't just swab the vagina, you swab the perineum and the anus as well. So the little swab has to go in all the holes. All the nooks and crannies. Okay? All right. Is that like information overload?